Hello, thank you for joining us for OrthoAlliance's OrthoInsights educational webinar series on overcoming arthritis. Tonight's speakers are Drs. Benjamin Pulley, Jeff Yergler, Edward Westerheide, and Mark Prissel. In addition to our OrthoAlliance physicians, David Rode, Executive Director for the Arthritis Foundation in the Cincinnati and Kentucky markets, will be speaking about what arthritis is and the many tools the Arthritis Foundation has to help patients navigate the disease. Speakers will answer questions following the presentations. Please type your questions in the Q&A box at the bottom of your screen. We will include all questions and answers on our OrthoInsights webinar series blog located on the OrthoAlliance website, orthoalliance.com. At this time, I'll turn it over to David from the Arthritis Foundation.
Thank you very much. I'm going to go ahead and share my screen here. All right. Hopefully that is showing up for you.
It is not.
Okay,
Yeah, I think it's still
sorry.
in. There we go.
Okay, terrific. Sorry about that, everyone. My name is David Rode, and I am with the Arthritis Foundation in Southwest Ohio and Kentucky. The Arthritis Foundation is a national nonprofit organization, and we're dedicated to helping people with arthritis live their best lives. So we do that through investment in science to find treatments and a cure, through patient support, and through advocacy. For my part of today's presentation, I'm going to provide some very basic information about arthritis and then spend a few minutes sharing some Arthritis Foundation resources that are free and are available to anyone at any time. I'm also going to share contact information for Arthritis Foundation staff in your local areas because we all welcome your questions, emails, and calls at any time. So, there we go. What does arthritis mean? Knees, hips, shoulders, elbows, these are all examples of joints, the parts of the body where two bones meet and move. The word arthritis is a medical term that literally means joint inflammation. But arthritis also refers to a group of over 100 different diseases. Arthritis affects not only joints, but sometimes other parts of the body, like the skin, the organs, or the tissue around a joint. Now, let's talk about some of the facts and figures of arthritis. This slide says it all about why the Arthritis Foundation exists. 1 in 4 Americans has arthritis. That's more than 60 million people. And that includes nearly 300,000 children, making it the #1 cause of disability. So let's think about that for a moment. As the #1 cause of disability, arthritis is far-reaching and truly affects everyone. And it's also expensive, and it threatens quality of life. At the Arthritis Foundation, we're making a difference in the lives of people. That's our goal, make a difference in the lives of people with arthritis, and we want to help save millions of dollars in healthcare costs. There are over 100 types of arthritis, as I mentioned, but we don't have time to talk about all of those tonight. So today we're primarily going to focus on the first one on the list, osteoarthritis, or as some of us call it, wear and tear arthritis. And the doctors on this call are going to be able to provide you with terrific information about treatment. Gout is also a type of arthritis that many people have heard of. And there are also many autoimmune or inflammatory forms of arthritis as well. And even children can get arthritis, something most people don't realize. Juvenile arthritis is an autoimmune form, and it affects hundreds of thousands of children, many of them right here in Cincinnati. If you have questions about these other forms of arthritis, the Arthritis Foundation can provide you with information and resources. I'll leave my contact information with you at the end, and you're welcome to contact any of us if you'd like to learn more. But the Arthritis Foundation website is another excellent source of information. Here are some services and activities that you can get involved in with the Arthritis Foundation. You can volunteer. This is at events or mission programs, and there are national opportunities as well. There are community coalitions, conferences, and connect groups. Education, local and national education, a Live Yes toolkit, podcasts, webinars, our website, or we have our helpline. We have social workers and experts who are standing by to help you solve any arthritis-related problem you may have or connect you to people who can. We have events, our Walk to Cure Arthritis, the Bone Bash, a car show, the Jingle Bell Run, and of course, advocacy. You can sign up and help the Arthritis Foundation make sure our laws are good for people with arthritis by sharing your story and help them to get the care that they need and deserve. Finally, here's our contact information, mine as well as that of my colleagues in Indiana and Central Ohio and Toledo. You're welcome to call or email any of us at any time. We're here for you, we all work together, and we would love to help in whatever way we can. And now, I'll hand it back to my other presenters.
Thanks, David. Now, Dr. Pulley will be speaking on hip arthritis.
David, can you unshare your screen, please?
Did that give it back?
Yes. Dr.
Okay.
Pulley, can you unmute? Thank you.
Sure. Thanks, David, and thank you for all the resources that the Arthritis Foundation provides for our patients. Thanks to OrthoAlliance for putting together this webinar on this important topic, and I'm very pleased and happy to talk about the topic of hip arthritis, specifically about treatment, including surgical treatments such as total hip arthroplasty. Just a little quick background on me. I've kind of done a little bit of training across the country, but I started my undergraduate in Ohio State, my medical school at Wake Forest, and then did a residency back in Central Ohio with Mount Carmel Health System. I then went to the West Coast where I did my fellowship in orthopedic trauma surgery with a focus on hip reconstruction, and subsequently came back to join the Orthopedic Associates of Zanesville in 2018, where my practice primarily focuses on hip arthritis, knee arthritis, and broken bones. So the first question that we were tasked with as presenters here was to discuss when to see a specialist. So specifically regarding the hip, seeing a specialist is something that you'd consider doing initially if there's an acute injury. So an injury that has caused difficulty with bearing a body weight, or an injury that causes something that we term mechanical symptoms. And so a mechanical symptom is a symptom that blocks motion of the joint or makes the joint feel locked or difficult to move in certain positions. And so when these type of acute injuries develop, that's a trigger to see somebody that specializes in orthopedics and hip disorders. Many of our practices in OrthoAlliance across the platform, and especially in Central Ohio, have walk-in clinics and orthopedic urgent care when these types of issues develop. You can come in and be evaluated by a specialist, oftentimes the same day. Now that's in contrast to other more chronic forms of pain. So we all develop these sort of aches and pains throughout the course of our life with activities and things like that. And many times they're not a big deal, where you do an activity and you're sore for a day or two and then it goes away, or it goes away with a little bit of rest. When those symptoms persist for longer, and I sort of arbitrarily tell patients a week or two, but it could be shorter than that, or it could be a little longer than that, depending on the severity. But the key thing is that the symptoms don't seem to be improving with a change to the activity. So if a certain activity brought on symptoms and then eliminating that activity doesn't improve the symptoms, or resting, or applying simple things like ice and over-the-counter medications like anti-inflammatory drugs like ibuprofen or acetaminophen, if those things aren't helping, then that would be a good time to see a specialist. And so when you come to the office and we evaluate the problem. And in this case, we're talking about hip arthritis. What treatment options are available? And so we always start with what we call conservative or non-surgical treatment. And this is typically decided after evaluation of the patient, oftentimes with imaging that might include X-ray. And then we discuss which of these non-surgical treatment options would be appropriate based on the diagnosis. And so when we're thinking about non-surgical treatment of hip arthritis, many times we start with looking at the activities. And so modifying the activities specifically for things that are acceptable to do with the symptoms that are present in the hip. Many times, decreasing the impact level of our exercises can help decrease symptoms in an arthritic hip. And so it has been shown that keeping the joint moving, keeping the joint active is beneficial. It does help to decrease some of the pain and symptoms. It's a little bit counterintuitive because patients often ask, well, if the joint's worn out, should I really be using it? And the answer is yes, but you want to think about the activities that are being done. And typically we think about low impact exercise. And so, the highest impact form of exercise would be, running out on a hard surface like concrete or asphalt. And some patients with hip arthritis can do that with some modifications, but lower impact forms of exercise would be things like swimming, maybe trail hiking, cycling, things that don't load the joint with as much body weight. There is oftentimes a role for physical therapy in treatment of hip arthritis, and physical therapy is different than exercise. They're not the same thing. And this physical therapy is a program directed by a licensed physical therapist to focus specifically on motion, strengthening, and deficits that are present around the hip joint. In America, one thing that we talk about often is weight loss. Unfortunately, there's a massive epidemic of obesity in our population, and that does correlate to extra pressure on the joint. Just like we talked about, high impact running, things like that puts a lot of pressure on the joint. Extra body weight also puts pressure on the joint. So the non-surgical treatment oftentimes involves looking at the body mass and deciding if there's a safe way and an appropriate way to bring down body weight. That often goes hand in hand with some dietary changes. The diet can affect the body weight, but the diet can also affect inflammation in the body. And so, like we were talking about earlier, arthritis is really inflammation of the joint. And so there are dietary things that can be done and have been shown to bring down inflammation. And oftentimes this would be referral or consultation with a registered dietitian. Moving up the ladder, we can then think about medications. And so there are many over-the-counter medications that are appropriate to use in the initial phases of arthritis. And the mainstay of these are what we call the NSAIDs. That acronym stands for non-steroid anti-inflammatory drugs. That would be the things like ibuprofen that you can buy over the counter. And they help to decrease pain in an arthritic hip because they decrease the inflammation. If over-the-counter medications aren't working, then you can talk with your provider about a prescription strength. There are some stronger forms of anti-inflammatory medications that are safe to use and potentially more effective that come in a prescription form. In addition to NSAIDs, you can consider using acetaminophen, which is Tylenol, an over-the-counter medication. And it can be used safely in combination with NSAID medications. Because it works by a different mechanism in our body. Rather than decreasing inflammation and targeting pain by decreasing inflammation, it's really blocking pain receptors and pain perception in the body. And so it can work synergistically with NSAIDs to help control symptoms. After medications that one would take by mouth, you could consider injections. When we're talking about the hip joint, injecting the hip joint with a medication is a little bit different than the average joint injection. Most other joints that you're going to hear about tonight, we can safely and effectively inject in the office. And sometimes that may be done with ultrasound in certain settings, but things like the knee joint, the shoulder joint, we can feel that joint beneath the skin and accurately introduce a needle safely into the joint and inject the medication. The hip's a little bit deeper, a little bit less easy to inject just by feel alone. And so if you're going to have your hip joint injected, I'd recommend you see a specialist that can do it with some sort of imaging. And that may be under X-ray or a portable X-ray style called fluoroscopy. Or you could sometimes do that with ultrasound, depending on the provider preference. The gold standard medication for what we inject that has been shown to be most effective is corticosteroid medication. So a steroidal anti-inflammatory medication. And again, it's targeting the inflammation in the joint to help bring down the pain and the symptoms. Besides steroid, there is a growing body of evidence and research that's supporting more biologic type anti-inflammatory injections. There's a product called platelet-rich plasma, which is actually essentially a concentrated filter of a portion of blood. So the patient actually has a blood draw from typically their arm, and the blood is processed to remove the platelets in the plasma, which carry the growth and healing factors that normally are present in our blood. We take that and inject it back into a joint that has some damage from arthritis, typically in the more mild or sometimes the moderate or medium types of arthritis. It can help to decrease symptoms, and there's some growing research to support this. We know that it doesn't restore the joint back to the pre-arthritic state. It doesn't cure end stage or the final stages of arthritis, but in early arthritis, it may be helpful. Lots of patients ask about gel injections, and as far as the hip is concerned, gel injections have never been FDA cleared for the hip. We do see some providers that occasionally use them off-label, but there is very minimal evidence in the orthopedic research to show that they're effective for the hip. After we've gone through discussing conservative management and figuring out which, if any, of those steps apply based on the symptoms and based on the severity of the arthritis for the patient, we then move on to considering surgical intervention. And when conservative treatment measures have failed, the surgical treatment for the hip is something called total hip arthroplasty, so a complete replacement of the ball and socket joint of the hip. And the general things that I counsel patients on when to consider total hip arthroplasty are what I have listed here, that the arthritis is affecting the quality of life, that it's impacting the day-to-day functioning, and it's something that bothers them on a daily basis. It affects the simple functions of normal life. And so for the hip, it's especially things like difficulty putting on shoes and socks, difficulty rising out of a chair. When the symptoms are severe enough to affect that level of activity, that's a good reason to consider surgery. We use an X-ray to help diagnose the stage of arthritis, and the joints that we replace are at a minimum in the moderate category of arthritis, but oftentimes the more severe form of arthritis. We also then have to consider the health of the patient. Not every patient is a good candidate to have a joint replacement surgery, and so we have to carefully look at the health status of the patient and make sure that their body is fit to undergo a major elective procedure. And then when it's all said and done, we have to discuss the benefits that can be had with joint replacement and the risks that are present. And what we always want is we want that teeter-totter to tip in the side of the benefits. We want there to be more benefits than risks to justify doing a surgery. So total hip arthroplasty, in a really quick 10-second nutshell, is basically where we go in and we remove the existing worn-out ball. So on one side, this patient's already had their hip replaced. On the other side, I'm going to show you kind of what the components are, but the new socket, we call that the acetabulum. That's typically a metal shell that goes into the new socket, and that's lined with a material called polyethylene in most cases, which is basically a really durable, really highly processed plastic. We place a titanium stem into the femur. This can be cemented into the bone in some patients. In other patients, it can actually be pressed into the bone so that the bone will grow into it. And that stem is what supports the new ball. And so in a nutshell, that's really what a total hip arthroplasty looks like. There's several different ways of performing total hip arthroplasty. I'm not going to belabor this point, but depending on the training of the provider that you've seen, they may do it different ways. And really what it involves is how to expose the hip joint. There's several different described ways to get down to that ball and socket. There's what's called an anterior hip replacement. There's anterolateral, and this is kind of going from sort of the front pocket to the back pocket. There's a direct lateral and a posterior lateral. When I think about how to get to the hip joint, the key is really how do we get there in the least traumatic way possible? We want to get to the joint without disrupting a whole lot of muscle tissue so that we can let the muscle behave more normally after surgery, more quickly, help to speed the recovery. And so, it's not really just the location of the skin incision, but it's what you do with the muscle beneath the skin incision that helps with the patient function. And so, my strong preference for how to replace a hip is with what's called an anterior approach. And so on the prior slide, that's the green line here. It's more towards the front. People hear about hip replacement from the front. That's what they're referencing. And there's been a lot of research on what may be the benefits of doing a hip replacement through that approach. The things that are most consistent in the literature and the research that's been done is less pain in the immediate postoperative period, quicker return to walking without assisted devices, a more normal walking behavior, so a more normal gait pattern, less presence of a limp after surgery, and importantly, a lower risk of dislocation and the avoidance of what's called hip precautions after surgery. The ability to do it anteriorly also helps with more consistent placement, especially of the new socket, the acetabular component. And when you think about this list of 5 benefit summaries here, it really boils down to 2 things. The first 4 are present because the anterior approach is muscle sparing. When we do an approach through the front of the hip joint, we can use a natural interval in the muscle where we're spreading one muscle one way, one muscle the other way. We don't have to actually cut through muscle fiber. And so if we preserve the muscle, it allows them to potentially behave more normal more quickly after surgery. And the improved placement of components helps because when we do this surgery in that approach, the patient's lying flat on their back and we can do the whole thing under intraoperative x-ray. So what do you expect after a hip replacement surgery? Briefly, the postoperative course is as follows. In most cases nowadays, for healthy patients, this is an outpatient surgery, meaning you can go home after surgery. You put your full body weight on the surgical lower extremity immediately after surgery. Patients are up and walking with a walker with some assistance, typically within an hour to 90 minutes after we've finished the surgery. With anterior hip replacement specifically, because we have been preserving of the muscle envelope around the hip joint, there are no precautions. And so it's really listening to the body, respecting the boundaries that the body is giving you, the signals that it's sending, but there's not a laundry list or even a small list of things that you can or can't do. You can't, not certain sleeping positions or sitting positions, standing positions. Those don't apply when the hip has been replaced from the front. Most patients walk with a walker for the first week and a cane in the second week. Most patients return to light, unassisted daily activities, so light things around the house without needing a whole lot of help in 2 to 3 weeks. But then after that point, gradually increase the activities that they're doing based on how they're feeling. Most patients are able to return to a pretty normal lifestyle in 2 to 3 months after surgery. Just one quick slide on the concept of hip precautions. So when I say no hip precautions after anterior total hip arthroplasty, these would be all the things that you may have heard from people who had a hip replacement and said, my doctor said I can't bend over at the waist. I can't sit and cross my legs. I can't twist my body. Those all apply when the hip is replaced via different methods, oftentimes from what's called a posterior approach. The anterior approach does help to eliminate some of those things. So it simplifies some of the instructions after surgery, as well as some of the precautions, predominantly the things that affect the risk of dislocation. That's all I had on the hip. Hopefully that was helpful, and I'll look forward to your questions at the end.
Thanks, Dr. Pulley. Next, Dr. Yergler will speak about knee arthritis.
Can you hear me okay?
Looks great.
Okay, wonderful. Yeah, thank you, Dr. Pulley. That was great. I forgot to do a bio slide, of course. I went to the University of Michigan. Sorry to hear that you went to Ohio State. But yeah, went to Indiana University for medical school, Duke for residency, and went to Rush in Chicago for total joint fellowship. And it was interesting to hear that talk because we're all talking about arthritis, and you're going to see a lot of overlap of symptoms, overlap of treatments. And I'm going to try to kind of speed through this so we can have a lot of time for questions at the end, just so that we don't repeat ourselves too much. We talked about what arthritis is. Arthritis is loss of cartilage, loss of cushion, causing the bones to grind and causing pain. There's a lot of different reasons that arthritis can happen, which the Arthritis Foundation talked about. But the end of the day, it's the same thing. You don't have any more treads on your tires, essentially. Treatments for knee arthritis. Conservative treatments, very similar to hip arthritis. Medications consisting mostly of anti-inflammatories. Anti-inflammatories are good at treating symptoms. They all have kind of the same baggage. If you take them long enough, they'll be hard on your stomach, your kidneys. They can raise your blood pressure. So they're a good short-term treatment. There's medications more aimed towards specific rheumatologic conditions like rheumatoid arthritis that directly affect the immune system, which also have a lot of side effects associated with them. Probably the mainstay for knee arthritis is injections. He alluded somewhat to this last time that injecting a hip is somewhat difficult because it's a little more difficult to get the injection where you want it to go, and the injections are not always helpful. With knees, they're predictably helpful for a period of time, especially with steroids. Steroids got kind of a bad name in the 70s because they were used for athletics and allowing athletes to participate with injuries when they shouldn't be. But for arthritis, once the joint is already worn out, it's a very good way to make the knee feel good without a lot of side effects. Viscosupplementation are the gel shots, which help in some people. I find that in most people, they're not great. Physical therapy is always an option, but again, if you've worn all the treads off your tires, then driving your car more probably isn't going to help things, because once cartilage is gone, it's gone. And if you see some people, I'm sure you've seen, the crooked knee, doing physical therapy with that knee is not going to help things. Joint replacement in its essence is just resurfacing the bone. I think there's a common misconception that you lob off the entire joint and replace it. That would actually be fairly difficult to do. Most joint replacements are essentially resurfacing procedures where you remove the diseased cartilage. So once you do a joint replacement, you no longer have arthritis, and that can relieve joint pain, motion, and get you back to back to your life. Joints were first developed in the 60s and the 70s. The biggest problem with early joint replacements were with getting them to not loosen and getting them to not wear. These are just some pictures of some of the early plastics that wore out pretty fast. And kind of the old dogma was you should wait as long as you can and wait till you're as old as you can to have your joints replaced because they wear out in 10 years. That doesn't really happen anymore. I think probably the biggest improvements happened in the early 2000s with the bearing surfaces, where they really just don't wear out anymore. That's true for hips and knees. They can have problems, certainly other problems, but wear seems to be essentially eliminated if the implants are put in well. So it's safe to say now that joint arthroplasty is one of the most successful procedures in the history of medicine, and there should be high expectations for longevity and performance. Now there's this whole new world of technology that's being introduced into knee replacements. Knee replacements are like changing tires. You have a flat tire, you have a worn out tire, you get a new tire. It's pretty simple, but we have all these things now that are being introduced, like wearable watches, robotics. We actually have implantable smart devices that are like Fitbits, so they tell you how you're walking, how you're bending and straightening, how you're recovering, potentially, if you're having problems with the implant. So there's this whole new world of technology that's being introduced into joint replacements. And I don't think we really know exactly where all of these are going to fall, but it is certainly an exciting time. What can you expect after surgery? Knee replacements get more stiff and sore than hip replacements. I know you just spent a lot of time talking about anterior hip replacements. I'm a total joint surgeon that does posterior hip replacements, and I can tell you that they recover quite quickly also. And so we all have kind of our opinions about what's good and what's bad, but most would agree that knees get more stiff and sore than hips, no matter who does them or how they're done. So there's been a lot of emphasis and a lot of research done into trying to get people through knee replacements faster with less pain. And this also has developed over probably the last 20 years, where we've modified the anesthetics, where we're doing mostly spinals without narcotics. We do special injections, all to try to make it so that it's less uncomfortable. These are often done as outpatients now, also at most overnight stay. And you can expect now that you should be walking immediately after surgery. You may use a walker for, I don't know, a week or two. Probably need 4 to 6 weeks of therapy to get motion back, depending on how motivated you are. But the knees, they do recover pretty fast now. So that's all I have on that.
Thanks, Dr. Yergler. Next, Dr. Westerheide will talk about shoulder arthritis.
Hello, I think Heather was going to show my slides, so I think they're coming up.
Can you see those?
Yes, so we can advance to the next slide. So a common question that patients might ask would be, when should you see a specialist for shoulder arthritis? Most patients, they don't necessarily know that they've got shoulder arthritis. They just know that their shoulder hurts them. And so one of the reasons to see a specialist would be to help define and diagnose what is the problem. There's lots of different types of shoulder pain and different etiologies and causes of that. And so you want to kind of determine, is this shoulder arthritis? Is this a rotator cuff tear, or is there something else going on with the shoulder, sprain, strain, whatever? So typically you've got pain in the shoulder, you've got stiffness in the joint, you've got a loss in your range of motion. Mechanical symptoms include grinding, clicking, or cracking, which is what we call crepitation or crepitus. You can see the pictures at the bottom of the slide. The far left shoulder picture shows a normal, healthy joint. You can see that white cartilage both on the ball and the socket. Cartilage's job is to really cover the bone and protect the bone. Cartilage, there's no pain when a normal, healthy joint works, because there's no nerves in cartilage. Cartilage can rub on cartilage from the day you're born to the day you die. If you have a good, healthy joint, you'll never have pain in that joint. Arthritis is when you lose the cartilage that covers the bone. There's lots of nerves in bone. If you break a bone, it hurts because there's nerves in the bone. When bone starts to rub on bone, the nerves in the bone on one side of the joint are rubbing on the nerves in the bone on the other side of the joint, and those nerves don't like that, so they send a message to the brain that you've got pain, and that's basically where the pain of arthritis comes from. You think about just boiling everything down. Joint replacements work by covering up the bone again, and we resurface the joint with metal and plastic. There's no nerves in metal, there's no nerves in plastic. Metal and plastic can rub on one another, and as long as the bones are happy again under the implants, the nerves in the bones are no longer sending a message of pain to the brain, and that's how joint replacement works for all different types of arthritic joints to solve the pain problem. You can do the next slide. So what treatments are available for shoulder arthritis specifically? Once you've seen a specialist and you have the diagnosis that it is shoulder arthritis, then we typically start with conservative treatment. Just as all forms of arthritis, typically that includes an anti-inflammatory and or acetaminophen. So acetaminophen, Tylenol, most people would take that as extra strength Tylenol, which is 500 milligrams in a tablet. We typically recommend 2 tablets each time you take it for a total of 1,000 milligrams. And typically we take that about every 8 hours. That's typically a very safe amount of acetaminophen, and it's safe for the liver, and it works. A lot of people that take acetaminophen, they really don't take enough, and they don't take it as often as they should to get relief. Anti-inflammatory medicines is the other common medication that's used. Those can be over the counter or prescription. Over-the-counters, typically Advil, Aleve, Motrin, Naproxen, those over-the-counter anti-inflammatories. I like a prescription anti-inflammatory called meloxicam, otherwise known as Mobic. The nice thing about it, it's one of the safest anti-inflammatories we have, and you only take it one time a day. So it's very easy to take and it lasts all day. And it's a little bit less likely to irritate your stomach or irritate your kidney or heart, etc. Some people use topical creams, anti-inflammatory creams exist, Voltaren gel, all the typical off-the-shelf creams that you can get, Bengay, Icy Hot, Flexol, BioFreeze, Blue Emu. You've seen commercials on TV, and some people use those types of creams, and they can help. The more aggressive conservative treatments would include injections into the joint. The most common and typically most studied would be a corticosteroid injection. Just like you can do in the knee and the hip, you can do it in the shoulder. And we can hit that joint pretty well just by palpation in the office and going through the portals that we typically use surgically. And that's been used for many, many, many years. Some people use hyaluronic acid. It's really not FDA approved. I'm not a fan of that because it's not FDA approved. And as a rule, hyaluronic acid has really not been shown in most joints to make a big difference. PRP has been discussed when it was talked about with the hip replacement. Again, it's kind of early infancy of knowing what the indications for PRP would be and how that really works. But there's not a lot of good literature that shows that it really helps arthritis of the shoulder, but they're continuing to study that. So that may be something that could increase in frequency in the future if it's shown to have better benefit. So exercise is important. One of the things that's not really been talked about is you get endorphins when you exercise. Endorphins are feel-good hormones that your body produces only when you exercise. And so getting regular exercise, your body produces endorphins, and it helps you to compensate for the pain of the arthritis. Physical therapy is a good idea. It doesn't have to be too many visits, but a doctor of physical therapy can give you a basic program that you can work on your range of motion so you don't get too stiff, and work on some basic strengthening so you maintain your strength and function. And again, just the endorphins that are released by exercising that joint actually helps to combat the pain at that joint. Alternative therapies would include things like massage therapy. You could consider acupuncture, bee sting therapy. There's all kinds of alternative therapies out there that you could try. Supportive garments. Some people would wear kind of a neoprene sleeve that gives a little compression. There's Tommy Copper things, questionable benefit, but they make those for almost every joint. Sling could be used intermittently. Braces are pretty rarely used on the shoulder. Heat and cold therapy, there's got a lot of benefits to that. A little bit of mild moist heat and some mild cold therapy, and alternating those especially can give some pain relief. So that brings us to surgical treatment. The two main types of surgery that could be considered for someone with shoulder arthritis would include arthroscopy and finally shoulder replacement. Arthroscopy, one of the main indications for that would be a subtype of shoulder arthritis. The subtype would include arthritis at the AC joint, the acromioclavicular joint. That's where the clavicle comes and meets the acromion. And that small joint, you can resect that joint, and that can give tremendous pain relief if your arthritis is basically isolated to the acromioclavicular joint. Some of the other reasons you might think about arthroscopy could include if you've got loose bodies in the joint, you could go and arthroscopically remove the loose bodies. If you've got a torn labrum, you could go in and trim that soft tissue that surrounds the socket to help minimize the mechanical symptoms of a labral tear. And oftentimes the biceps tendon can also start to shred and tear, and doing a biceps tenodesis arthroscopically is another thing that could be done to minimize pain in early stages of shoulder arthritis. When the shoulder gets arthritic enough, typically we resort to shoulder replacement, which is very similar to what you've already heard with hip replacement and knee replacement. Basically, we remove some bone, and when we remove that bone, we replace the bone that we removed with a metal and plastic joint. And that solves the pain problem because metal and plastic don't have nerves, and the bones are happy again under the implant. And actually the function is quite good. There's two main types of shoulder replacement. One would be an anatomic shoulder replacement, which maintains your anatomy the way God made you. And the other is a reverse shoulder replacement. And we'll get into that very shortly. So next slide would be shoulder arthroscopy. We talked about this. It's typically for earlier stages of arthritis that are not that severe. We can direct this treatment at a loose body in the joint, a little piece of bone that's drifting around. If there's some torn tissue around the socket, the labrum, if the biceps is torn, if you've got AC joint arthritis isolated, we can resect that joint. It's called a distal clavicle resection, otherwise known as a Mumford procedure. And those procedures can be very, very helpful. There's lots of people that have earlier stages of arthritis where the arthritis is really not that severe, but yet they've got a lot of pain from these other diagnoses that you can kind of cure and resolve pretty well with arthroscopic techniques. So the next slide would go into shoulder replacement. The procedure is typically called a total shoulder replacement. You know, some of the earliest shoulder replacements were called hemiarthroplasties. That's when we did not replace the socket. They had inferior outcomes, and so that's pretty rarely used today. Typically, almost all surgeons would elect to do a total shoulder replacement, which means you replace both the ball and the socket. If you look at the right-hand side, the top picture actually shows a picture of arthritis of the shoulder. You can see that there's not much space on the radiograph between the ball and the socket. That kind of shows that the bones are rubbing together, and that's where the pain of arthritis comes in, because the bones are rubbing and the nerves in the bone are irritated with that process of heat and friction. The second picture down, the middle picture you see is a picture of an anatomic shoulder replacement. You can see that basically we resurface the joint and we don't really alter the anatomy. You still have the ball where the ball's supposed to be, and you still have the socket where the socket's supposed to be. On the socket part, you can't see much there because that implant is primarily plastic. There's just a little radiographic marker in the middle of that socket that kind of shows where we've placed that implant. The bottom picture is an example of a reverse shoulder replacement, and you can kind of see why we call it a reverse shoulder replacement, because we put the ball on the socket and we put the socket where the ball was. So we reversed that anatomy. You can also see that we kind of lengthen that arm. If you look at the distance from up at the clavicle to the top of the shoulder, it's longer on the bottom picture than it is in the middle picture. And that helps to kind of stretch the deltoid, and it facilitates the deltoid being the prime mover of the shoulder after reverse shoulder replacement. One of the main reasons to do a reverse shoulder replacement would be if you've suffered a major rotator cuff tear that could not be fixed. And that would still allow you to solve the pain problem of the arthritis by doing a joint replacement, but also improve function by restoring the ability to raise your arm up overhead by using your deltoid. So that's basically how joints work and the major types of joint replacement. We can move on to the next slide. What can you expect after surgery? So now, thankfully, shoulder replacement just in 2024 has become an outpatient surgery. We now can do that at an ambulatory surgery center, which is where most orthopedic surgeries are now done. Most orthopedic surgeons would prefer to operate at an ambulatory surgery center because typically it's better for the patient in a variety of reasons. I do almost all of my surgeries outpatient now. That includes hip replacement, knee replacement, shoulder replacement, rotator cuff repairs, fracture work. It's amazing what we can do on an outpatient basis at a facility that is geared towards just doing orthopedic surgery. So what you can expect after surgery, arthroscopy, it's outpatient. You get it done, you go home the same day. It's typically done through about 4 small wounds, one in the back of the shoulder, one in the front of the shoulder, and typically 1 or 2 on the side of the shoulder. That's pretty straightforward. You take your dressing off after a day or 2. You've got those small little wounds. You see us back in the office a week and a half to 2 weeks after surgery, and you start your process of recovery, which includes some physical therapy. There's obviously some restrictions based on exactly what we did and what your diagnosis was, whether that was an arthroscopic procedure or whether that was a shoulder replacement, but you'll have some instructions. Typically, we instruct you before the surgery. I like to make sure that people go to physical therapy before the shoulder surgery so that they have a better understanding of what they need to do right after the shoulder surgery, and also to set up an early physical therapy appointment after the shoulder surgery. So shoulder replacement, very similar. Now it's something that we can do outpatient. People get it done, they go home the same day. And it's we use regional blocks when we do shoulder work. So it's very effective. The anesthesiologist will actually numb some of the nerves around the shoulder before you have your surgery, and that block still stays in effect, very similar to a dentist who numbs your mouth before he pulls a tooth. and that block works for many, many hours after the surgery. So you get home before that block starts to wear off. And so shoulder surgery used to be one of the more painful surgeries, but now with revolutionary anesthesia techniques and the regional blocks, it's really improved pain control. And so shoulder surgery is much less painful than what it used to be just a number of years ago. So follow-up appointments we schedule with the surgeon. Typically, that's a week and a half to 2 weeks out for your first post-operative check. Oftentimes, that would include getting some x-rays after the shoulder surgery to check on the positioning of the implant, if you had a joint replacement, or potentially the resection of bone if you had an arthroscopic procedure. There's a slow, steady progress of recovery. I like to tell patients as soon as you wake up from your shoulder surgery, if it was a joint replacement, you can say, hey, I no longer have shoulder arthritis, and you do not have the arthritic pain that you had before the shoulder surgery. You wake up, there's a different type of pain. You have some pain because we just did shoulder replacement or an arthroscopic procedure, but the main reason for your pain before the surgery is gone. And the surgical pain, that's a pain that's it backs off pretty quickly, and before you know it, you're much happier and much more functional with a joint replacement or an arthroscopic procedure about the shoulder. The next slide is my introductory slide. I've been out in practice since 1998. I went to the University of Dayton for my undergrad. I then went to the Ohio State University for my medical school training. I went up to Henry Ford Hospital in Detroit, Michigan, a very tertiary trauma center and very, very busy surgical hospital, and had great training there. And I'm born and raised in Mount Vernon, Ohio, which is not very far from Newark, Granville area where I practice. And I've enjoyed my 26 years of practice so far and look forward to additional time and seeing patients. So come see me if you have any shoulder problems. Thank you very much.
Thanks, Dr. Westerheide. Lastly, Dr. Prissel will speak about ankle arthritis.
Just finding my presentation to share. Give me 1 second. There it is. All right, sorry for the delay there. My name is Mark Prissel. I'm a fellowship trained foot and ankle surgeon with Orthopedic Foot and Ankle Center in Columbus, Ohio. We're going to be talking about ankle arthritis and some of the applications and treatments that we can do for that. So similar to what's been talked by the other presenters and for other joints, when should you see a specialist? It's when you really have limitation in your desired activities, and when some of the very similar described either self-cares or cares that would have been recommended by your primary care physician are not providing appropriate relief. These are over-the-counter medications, activity modifications. In the foot and ankle, it can be modifying or changing shoe gear, using a variety of different type of bracing, as well as additional modalities. There's no real particular restriction on time when you should see a specialist. We see some patients that come to see us when they've had pain only for a few days or weeks. And then some people have been dealing with this for several years by the time they make it to us, and they've been interacting with their primary care physician or seeking other options for treatment prior to that. But if you're concerned about your pain and your pain isn't improving, I think that's really the time to see a specialist and somebody that's experienced with the specific area of your body that's causing the problem for you. Orthopedic Foot and Ankle Center is the largest multidisciplinary foot and ankle subspecialty practice in the country. One thing that's a little bit different about our practice is our entire practice is focused on foot and ankle care. Most orthopedic practices have specialists that focus on various areas of the body. With ours, we're highly subspecialized and focused only on the foot and ankle, which makes us a little bit different. When it comes to treating ankle arthritis and doing ankle arthroplasty or ankle replacement, we're one of the highest volume total ankle replacement practices in the country. We have locations throughout Central Ohio, and we have multiple fellowship trained foot and ankle surgeons who are trained and experienced with a variety of different total ankle replacement systems that are out there. And so when we're looking at the causes of ankle arthritis, what about it is similar and what about it is different to others. One of the main causes for ankle arthritis is chronic instability of the ankle joint. Those who are loose jointed, people who have struggled with multiple prior sprains, either from athletic activities or just general walking activities. Sometimes people have difficulty with multiple sprains over a lifetime that they didn't really treat 10, 20, 30 years ago. And over time, that weakens the joint and causes the cartilage or the lining of the joint to rub against each other, and it can wear the cartilage down more rapidly. Inflammatory arthritis, such as rheumatoid arthritis, is another problem that can cause ankle arthritis. And then people who've had prior trauma to the ankle. One thing that's a little bit different with the ankle joint is it's not as frequently simple wear and tear. The number of steps you take in your life doesn't necessarily cause your ankle joint to wear out, so long as you have good stability to the joint and you haven't had prior trauma to that joint. So what treatments are available from the non-surgical standpoint? It's very similar to what was talked about by the other presenters. Modifying activities, using those anti-inflammatory medications, changing your shoes, trying to use a brace of the ankle. Injections are also an option. And similar to the other joints, corticosteroid injections tend to be the gold standard. The gel type injections are not FDA approved to be used in the ankle joint. Some people do choose to use them off label, and there's limited evidence on PRP in the ankle joint as well. What are the indications to consider a more definitive procedure for your ankle? Well, first off, you have to have arthritis in the ankle. And then we assess as well what's going on from a deformity standpoint. When you look at the foot and ankle, there's many small joints that are just below where the ankle joint sits. And sometimes those joints may have problems, or the bones within the foot may have problems that would make it so that the ankle joint may not be as successful. So in some instances, we have to correct a deformity or problem in the foot first before we would move forward with an ankle joint replacement. Some of that stuff can happen at the same time, and you rely on your experienced surgeon in total ankle replacement to help you make those decisions if it's safe to do it in one surgery or if it would be a better choice to do it in 2 surgeries. We look at what's going on at the neighboring joints. Again, there's many small joints in the foot that can be impacting what's going on in the ankle, and also what's happening at the knee can influence what's happening at the ankle as well. We look at the age of the patient. Generally, when we're doing ankle replacements, historically, it's been those that are 50 years or older. As we've seen improved success with total ankle replacement, that age restriction is starting to move down, where now if you're a little bit younger and not overly active, you may be an appropriate candidate. We do take into consideration BMI and weight as well. And as with any joint replacement, you want to ensure that there hasn't been a prior infection, or that there certainly isn't an active infection in that joint. And then to have normal sensation. Neuropathy is a disease that can cause the nerves to not act appropriately, and it can be somewhat common in the foot or ankle, or in the more distal extremity as you get farther away from where your spine is, and that can have some impact on how successful a surgery can be in the ankle joint. This is a little different compared to the other joints that we talked about. An ankle fusion, where we actually look to anchor 2 bones together, for certain patients can be an appropriate management strategy for ankle arthritis. It can be a good procedure for pain relief. And in some procedures, or in some circumstances, it may be the best option, or really the only option if they're not a good candidate for total ankle replacement. The downside of an ankle fusion is the neighboring joints right below the joint, or right below the ankle joint, or in front of the ankle joint. It can accelerate arthritis in these joints because the ankle joint isn't able to move anymore after a fusion is done. And generally what we're seeing in terms of the literature is if people are an appropriate candidate for a total ankle replacement, the outcomes for them are leaning toward you probably should do a total ankle replacement if they're a good candidate, rather than an ankle fusion. But again, for pain relief and in certain patients, an ankle fusion is the appropriate option. Understanding deformity, like I said, because not only can there be deformity within the ankle itself, there can either be deformity above or below it. And at our Orthopedic Foot and Ankle Center location, we have a special type of a CT scan called a weight-bearing CT scan that allows us to assess these deformities while people are standing. And that can help us understand really what components of the deformity are influencing what's happening at the ankle joint. It's an efficient process. It's an open machine in a reasonable sized room. And so it's a non-claustrophobic scanning experience. This allows us to get more detailed imaging and provide best patient experience and outcome. And again, it shows those deformity in stance or weight bearing. And then there are certain implant systems that have protocols that can create, based off of these types of scans, custom cut guides for the ankle replacement to help us execute the procedure on the day of surgery. So we are able to do some of our planning for the surgery before the surgery actually happens to limit the amount of time that you're on the operative table and the decision making that's needing to happen at the time the surgery is performed. When we look at implant types, very similar to what's been described for other joints, it's essentially a combination of metal and specialized types of plastics. And many of these are resurfacing type implants trying to restore as much bone as possible. Although in the ankle joint, when deformity is present, sometimes we use a stemmed device that has components that go up into the shin bone to help provide more support and stability. So for surgery and then after surgery, this, similar to the other joint replacements, can often be performed outpatient, and that tends to be our preference. So long as it's appropriate with your insurance and your medical health, these tend to be performed outpatient. Similar to what Dr. Westerheide said, as of 2024, some of the insurance laws have changed, and total ankle replacements are now more frequently able to be performed outpatient than they were previously through ambulatory surgery centers. The surgery typically takes an hour or maybe up to 2 hours, depending on the complexity, and it is done under a general anesthetic with, like Dr. Westerheide said, similar to the shoulder, with a regional anesthetic block to help control your pain afterward. And when it's done outpatient, to allow you to get home and start taking your pain medicine before that nerve block would wear off. What's different about a total ankle replacement is typically we have to keep you non-weight bearing for a period of time. In our practice, generally that's about 4 weeks. That isn't so much for the bone and the implant to bond together as it is for the skin to start the healing process and the early phase of the implant to start to seed where it's supposed to. We use cold therapy to help control edema and elevation as well in those first few weeks after surgery. We start physical therapy typically at week 4 after surgery. And then once patients are able to put weight on the foot, and they often go into a walking boot, which they're in for another 3 weeks or so. And then we may use bracing if it's needed to help provide additional stability up until about 3 months after surgery. That isn't always required, though. In terms of restrictions after surgery, really, we're trying to avoid those high impact loading activities that others have talked about as well. It's really running and jumping that we're trying to avoid afterward. I have my ankle replacement patients that play golf, doubles tennis, pickleball, skiing, surfing, cycling. Those types of activities tend to be okay. But again, focusing on the lower impacts. And then we do see our patients annually to monitor the implant. Complications and risks. In the short term, we're concerned about infection and wound problems. And so we see you regularly and keep the weight off the foot for the first few weeks to help minimize these risks. Long term, it's pain, implant loosening, subsidence, or wearing out of that plastic liner. Like Dr. Yergler had said, the technology within the plastics and the components has improved substantially. So some of that's a little bit more historic, and the prognosis and long-term outcomes of these implants has significantly improved over the years. This is a question that sometimes patients have, or sometimes we have to help redirect them. If you have a knee problem as well, or if you have arthritis in your knee, especially if there's deformity present in the knee, you're generally going to need to get the knee addressed first. And so you may come see us as a foot and ankle specialist, and we may say, it's actually not the right time to have your ankle done. We need to help refer you to a OrthoAlliance partner practice who specializes in knee arthroplasty to get that corrected first, and then they would send you back so we can manage the ankle thereafter. So that's a common thing that we see, and something that you should be aware of is if you have arthritis in both places and you're unsure which one to correct first, general principles would say that you should do the knee first and then your ankle thereafter. Just a couple quick examples of ankle arthritis. Here, the image of the right side, which is on the left-hand side of the screen, shows that joint space narrowed, and on the opposite, there is what a normal ankle joint would look like that does not have arthritis from the same patient. Here's what the side view looks like, where you see the big spurring in the front and the back, and really bone-on-bone arthritis through the entire level of the joint. And so here's an example of the special CT scan that we get that looks at what's happening at the knee and the ankle to help us build the guides that place the implant in the appropriate position in the most efficient way possible during the surgery. And then afterward, what it looks like with the ankle joint, you can see the space there where the plastic liner is in between. Here's an example of a case that has, I would say, mild to moderate amount of deformity, where there's more tipping of the bottom bone of the ankle joint called the talus, and the joint is more worn out on that side. There is also some deformity in the foot in this case, and this was a patient that had pain both at the joint below the ankle as well as the ankle. And so the ankle joint is crooked. And what we do with this is I chose to use a stemmed implant that goes up into the shin bone here. And because they had pain in the joint below, at the same time, we anchored those two bones below the ankle joint together to help provide improved pain relief at both levels of arthritic joints, one by doing a fusion and one by doing a replacement of the ankle joint. And by doing so, we improved the overall posture of the foot. That one I will skip over. It's a little bit more complex, but again, you can see that sometimes things need to be done in a staged fashion to help straighten everything out. And so from a final thought standpoint, if you have ankle pain, deformity, or arthritis, it's important to see a specialist to understand your options. Both surgical and non-surgical options exist, and experience matters. Thank you.
Thanks, Dr. Prissel. At this time, we have about 15 minutes remaining in the webinar, so we will answer your questions. And as a reminder, please type your questions in the Q&A box at the bottom of your screen. If your question is not answered live tonight, we will have all questions and answers on our blog by the end of the week, and you can find that at OrthoAlliance.com. And it will include questions and answers from tonight as well as the previous two webinars. So first question is for the knee. In utilization of the Gelslin shots prior to any knee surgery, is the pain expected to totally cease or just become manageable or less severe?
Yeah, I would say that injections vary tremendously between patients. Some patients react very well to certain injections and others do not. I find that the cortisone injections tend to work the fastest and work the best. Gel injections are more hit or miss. Some patients really love them. I find that more often than not, the patients don't feel like they did much at all. And insurances have kind of picked up on that. So if you're a Medicare patient, they'll usually cover the gel injections. If you're a private pay patient, they're usually not covered and they're pretty expensive. So yeah, and any type of shot for arthritis is a temporary fix, and just varies a lot from patient to patient how long and how well they respond.
Thank you. And then to add to that, please review meniscus tears and how the Gelslin shots affect pain in the knee. The question is, I've been told people live through tears, however, it's very painful.
Yeah, once cartilage is torn, it's torn. It doesn't have the ability to heal itself. There are different ways to tear cartilage. If you're 20 years old and you're a football player and you get hit on the sidelines, you can tear your cartilage. But in this patient population, it's usually more from wear and tear and a degenerative tear. You see it a lot in patients that have arthritis and have MRI scans. I would say that every patient who's over the age of 50 or 60 who has an MRI scan is probably going to have a cartilage tear to some degree. And whether or not those are important or not really depends on how worn the joint is. It's not, the problem with the gel injections is there's a lot of marketing involved with those and a lot of claims, even based off these questions. Is gel shot going to fix a cartilage tear? No. Is a gel shot going to fix arthritis? No. Can you get some relief in either situation? Sometimes.
Thank you. Next question is, how do you decide which knee to have replaced first when both knees hurt?
I would say the one that hurts more. It really doesn't matter. They're both going to end up getting replaced, but that brings up a good point. It used to be common to do both knees at the same time. It isn't really done as much at the same time anymore, just because the complication rates are higher. There's been a big push to try to get people to get through these faster, to recover quicker, shorter hospital stays, shorter rehabs. And when you do them both at the same time, every single complication goes up, from blood clots to pain medicine problems to medical conditions. So most of these are done one at a time. I think you'd find a wide variety between doctors on how soon they'll do them. I usually like to wait probably 6 or 8 weeks between knees if people are in a hurry. I have colleagues that will do them much sooner than that. I guess it all kind of depends on your overall health condition and how anxious you are to get them done, but it is better to do them one at a time.
Thank you. Next question is, what is the most effective diet to control osteoarthritis?
Well, I'll jump in there, and the best thing to do is to find a registered dietitian, as one of the physicians mentioned, or to talk to your physician and get their recommendations because they know your health. But on the arthritis.org website, right across the top, there's a menu of topics, and there's a health and wellness section. And if you click on that, there are a number of articles about different anti-inflammatory diets, Mediterranean diet, others that have some evidence of helping with inflammation. But every person responds to diet differently, and that's why it's good to contact your physician and also get their input.
Thanks, David. Next question is, at what point is PRP ineffective?
I'll jump in and answer this one. So the PRP, again, this is currently it's experimental treatment. So I had mentioned that as an option, but I have to make the disclaimer that it is still under research. It's experimental. It's often, or it's not covered by insurance presently. That being said, the research that's been done for use in arthritis seems to indicate, at least now, that it would be most effective in the mild to perhaps moderate forms of arthritis. It's least effective when arthritis is more severe.
Thank you. Next question is, what is the desired BMI for joint replacement?
Weight plays a big role in joint replacement surgery of all the joints that have been mentioned here. Primarily, it increases the risk factors for anesthesia, risk factors for wound healing complications, and infection. Every provider has their own criteria, but generally there's some sort of a BMI where you think the risk is too high, and a BMI where you think the risk is acceptable. For me, I typically use a BMI of approximately 40 on the BMI scale. And so you can use a BMI calculator on an app on your phone or online to figure out the BMI, which is a ratio of your weight and your height. That being said, there's more and more research that seems to support that maybe it's not just purely the BMI, but actually initiating some weight loss. And so initiating a weight management program with a reduction in 15 to 20 pounds and bringing the BMI down, to a certain level might actually be more important than bringing it all the way down below 40.
Thank you. This next question is about the ankle. If there is a proximal issue such as knee or hip, should that be addressed first if there's no major deformity? And please define what is a deformity.
Yeah, so generally a deformity, how we think about it in terms of the ankle joint for what's happening at other joints, most commonly the knee, is if there's an angular change in one of the bones, either the tibia or the femur on each side of the knee, that may influence something. Because once you set the ankle in its position, if you then have a procedure done where the position changes at the level of the knee, the ankle may no longer be in the right position. And so that's typically going to come into play. And Dr. Yergler, feel free to jump in. If the patient is either bow-legged or knock-kneed, or if they have arthritis that's affecting one side of the knee or the other, or if they have pain in the knee, we're probably going to send to have it looked at first. Sometimes you have to get x-rays that include the whole limb so that you can understand where these angular relationships are to make sure that we're putting these joint replacements in the correct position.
Yeah, I guess my only comment on that is with knee replacements, by the time you get to a knee replacement, you usually do have some kind of angular deformity, and you do have the ability to change the limb alignment significantly. And different surgeons will have different philosophies on what they feel is the proper alignment, but you will change the alignment significantly. So that's kind of what he's alluding to, is before you have your ankle fixed, you probably want to know what the alignment of your extremity is first. So that's why the knee is usually addressed first.
Thank you. This next question is about the shoulder. And it says, is Dr. Westerheide using more reverse shoulder replacements nowadays?
There has been a trend, especially in older patients, to do more reverse shoulder replacements. One of the reasons for that is if there was a problem with the healing of the rotator cuff that you have to take down and repair with an anatomic shoulder, you would still have pretty good pain relief with an anatomic shoulder replacement, but your function could be impaired. And so, there used to be thinking with reverse shoulders that you want to keep those at age 70 or more, because there was some questions about their longevity. But as we've been doing more reverse shoulder replacements and the technology and implants have improved, some of the concerns that we had earlier on with those age limits have been going by the wayside. But so yeah, we do more reverse shoulder replacements, especially in people that are a little bit older. If you're still quite young, you're in your 50s or 60s and very active, if your rotator cuff is strong and functional, I still would typically recommend and perform an anatomic shoulder replacement.
Thank you. This next question is about the hip. It says, I know that chromium has caused issues. Do you use ceramic for the implants in hips?
Good question. So the stimulus of that question probably comes from the widely publicized recall of what was called metal on metal hips, which were really popular in the first decade of the 2000s. There was a lot of companies, well, several companies came out with a hip replacement where you had a metal ball, so an alloy metal containing cobalt and chromium that was basically rotating, articulating on a metal socket of the same type of alloy metal, cobalt and chromium. It performed really well in laboratory testing, but in humans it turned out to actually cause a lot of metal ion generation. So, microscopic particles of metal that were produced in the body and caused problems. So those were all recalled. There's no metal on metal hip replacements on the market now. And so that's really the key thing, is thinking about metal on metal. There still are metal balls that can be used and are very effective and very well supported in the literature. So you can have a metal ball for that ball and socket joint, but that would typically go onto a polyethylene or plastic liner of the socket. I prefer a ceramic ball. It's been shown to have slightly lower wear rates than the metal ball. I prefer a ceramic ball with a polyethylene liner. There's also an option of using a ceramic ball with a ceramic liner. But yeah, the thing to think about is just that metal on metal, which is not available currently.
Thank you. This next question says, how often can a knee patient get cortisone injections? I prefer gel injections.
Yeah, there's been a lot of questions about injections, and you see that a lot because no one wants a knee replacement, and so everyone is trying to kind of get the magic injection that's gonna make them get better. And unfortunately, a lot of people get taken advantage of with that. We have some companies locally that will make people pay out of pocket and take a lot of money from people trying to give them all kinds of magic shots that are going to make them better that don't really work. The injections are fine. Gel injections are fine. They're safe. They're great. If they give you good relief, then get them, because there's really no side effects to them at all. And you can do as many of those as you want. Cortisone shots, that varies a lot between physician also, and there's not really a lot of good studies on how many cortisone injections you can get in a knee safely before you start to have problems. I'll usually give them to patients every 3 months, and if they want them, and at some point, if they're getting multiple injections and their arthritis is bad, you kind of nudge them that maybe they should get their knee fixed. If you get too many cortisone injections in the knee, you worry that it could weaken the tendons. You could have a tendon rupture, which would be bad. I don't know if I've ever seen a patient that I thought had a tendon rupture because of too many cortisone injections in a knee. There's a lot of patients that just aren't good surgical candidates, like if they're older or sick, that I'll give cortisone injections to every 3 months and have for years and years, and never really see a problem from that. But if you have a fixable problem, if you have an arthritic knee, if you have a flat tire, at some point you should get a new tire, right? You can't just keep putting air in the tire. It needs to be changed at some point. So if you have a good reason not to do it immediately, or you want to try to put it off, fine. But the implants, they last so long now, they don't really wear out anymore. If you're kicking the can down the road, that's not usually a very good strategy, because all you're doing is making it less safe and less effective when you have your knee actually replaced. So if people want cortisone shots, we'll do them, but at some point we try to nudge them to just get it fixed.
Thank you. And we have time for one more question, and that is, what parameters make a good candidate for a total ankle replacement?
Yeah, so generally the normal, if that's such a thing, patient for a total ankle would be someone who has normal sensation in their foot, who isn't overly active. And so we look at someone who, if they're like a heavy manual labor or something, or they're on a lot of uneven surfaces or doing a lot of loading activities, those are ones that may be a better candidate for a fusion. So if you have good BMI is different, like Dr. Pulley said, for everybody, what exactly the right number or criteria is. But a reasonable BMI with good sensation and bad arthritis in the ankle is really the best candidate for an ankle replacement. Age has become less of an issue. Generally, it used to be that you wanted your patients to be 50 or 55 or older. There are instances where it is safe and appropriate to do that in certain circumstances, and even younger patients. And then the other thing we didn't spend any time talking about tonight is when we do an ankle fusion, typically it's recommended to do a technique where you save both sides of the ankle joint, so that at some point in the future, that could be converted to an ankle replacement as well. And so there's not one dead set of criteria that makes sense. That's why you want to see someone who's specialized and experienced in these options of both ankle fusion and ankle replacement to help you decide which one is the most appropriate option.
Thank you. So this concludes the educational webinar series on overcoming arthritis. As I mentioned earlier, if your question was not answered live tonight, we will have all questions and answers from tonight's session, as well as the other 2 recordings, on our blog, which can be found at OrthoAlliance.com. All recordings will be available on OrthoAlliance's YouTube page at youtube.com/@OrthoAlliance. For information about future webinars, please visit OrthoAlliance.com/events. Thank you and good night.